So good evening, everybody. My name's Karen Ahrens. I'm one of the GP advisors with the GP integration unit at Western Health. And as no doubt you know, you're here to see a wonderful webinar on paediatric developmental hip dysplasia. I'm looking forward to it. So I'd just like to read out this acknowledgement of country first. So the Northwestern Melbourne Primary Health Network and Western Health would like to acknowledge the traditional custodians of the land on which our work takes place. The Wurundjeri Woiwurrung people, the Bunurong people, and the Wathaurong people of the Greater Kulin Nation. And we'd like to pay our respects to elders past, present and emerging, and as well as pay respects to any Aboriginal and Torres Strait Islander people in this session with us today. We're committed to the healing of country, working towards equity in health outcomes and the ongoing journey of reconciliation. Western Health and the Northwest Melbourne PHN is committed to respectfully listening and learning from Aboriginal and Torres Strait Islander people and wholeheartedly support their journey to self-determination. So for many of you who've been to our webinars before, these slides will look very familiar, so I will try not to dwell on them for too long, but for those who are new to these webinars, I'll quickly read through them. So some housekeeping, all attendees are muted. So there are two options to you. One is the Q&A box, which is the main one. And if you've got questions throughout the session, please do feel free to write those. Mostly we'll be addressing those, the presenters will be addressing those at the end of the session. But sometimes they get addressed along the way live, but generally at the end. As it says here, the session is being recorded, but the questions will be anonymous, so they won't come up in the recording. And the recording will be sent to you via the email that you've registered within about a week's time. The other option, other than the Q&A box, is the chat box. Now, the only time to use this is if you think our lovely Yvonne, who's with us from the Northwest PHN, might not see your name, know your name, due to your name being labelled differently in your Zoom box or what have you. If that's the case, please write in the chat box and tell her what your name really is, and that's important for retaining CPD points. We can't confirm your attendance otherwise. So that's that. Before I introduce our speakers, I'd also like to introduce, I've mentioned Yvonne Beast. Thank you, Yvonne, for all your hard behind the scenes work. I'd like to also introduce Joan Silver, who's one of the GPs, we also one of the advisors with the GP integration unit from Western Health, who's here. Thank you, Jo. But let's move on to our speakers. So we've got two wonderful speakers. We've got Amelia and Chris today. So Amelia is an advanced practice physiotherapist who's got a special interest and extra training in paediatric orthopedics. She works at Joan Kirner Women's and Children's Health Hospital at the Sunshine campus of Western, and particularly in the area of babies and infants with developmental dysplastic hips and congenital telepies, and a few other things there that you can see, which is great. And so thank you, Amelia, for coming along tonight to speak with us. Our other speaker is Dr. Chris Harris, who's a paediatric orthopedic surgeon, and he's completed all of his training over in the UK initially, and then did further training in various areas in Melbourne and the US, particularly in paediatric orthopedics, which is obviously relevant for tonight. And he's at RCH in Western, and of particular, obviously, interest for tonight's session at Western, he manages children with developmental dysplastic hips, right from infancy all the way through to adolescence. All right, so I think that's enough from me. I'm going to stop sharing and hand over to Amelia and Chris. Thank you.
Thank you very much, Karen and Jo, for inviting us this evening to talk. Let me just work out screen sharing. Hang on a second. Okay, so welcome to our presentation tonight on developmental hip dysplasia, a GP update. So thanks to Karen for already introducing us. My name is Amelia. I'm an advanced practice physio working at Western Health, and I'm presenting tonight with my colleague Chris Harris, one of our orthopaedic surgeons. So thanks for inviting us tonight. Thank you to Karen for already going through the acknowledgement to country for us. We won't go through it again. So in terms of learning outcomes tonight, During today's session on DDH, we'd like to provide a basic understanding of the pathophysiology and discuss the screening pathways and risk factors. We'd like to provide you with a basic understanding of clinical assessment and management options. We'd like to discuss referral pathways to our DDH clinic at Western Health. So some of these may be slightly different for other services and interstate services. I'd also like to ask everyone tonight, if you have your phone handy, I was just going to have a couple of Slido questions. So they're live polls. So if you could get your phone handy, I've got a question upcoming. So I'm just going to change my sharing just for that. Might be a second. Sorry. So you should be able to see the Slido QR code. So if you can get your cameras open and scan this QR code, I'll just give you a minute to pop that in. That should go then to a link on slido.com. Just give you a minute for that, and then I'll start the poll. So my question is, what are you hoping to learn from today's presentation? I'm just going to start that poll now.
And just a reminder to click on the tab polls at the top, because it starts on the Q&A automatically.
Thanks, Karen. Examination, great. So lots talking about screening, guidelines, when to refer, referral pathways, when imaging is indicated, management of DDH, physio involvement, updated guidelines, assessment. Got 2 more people typing, and then we'll switch back. Protocols. Excellent. Thanks so much for participating. I'll just switch back to our slides now.
Thanks, Mel. In terms of the normal hip, I like to think of the hip as well, it's a relationship between 2 bones. In med school, we go and we learn this fancy word joint, and we get all fancy about synovial joints and blah, 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 blah. But actually, a joint is where 2 things meet each other. And so you have a relationship. That's all right. Yeah.
Sorry.
Excuse us.
There we go. Nearly there.
Yeah. So in the joint, hip joint, you have a relationship between the femur and the pelvis. And that relationship starts in utero, but it continues during childhood. And so number 1, we've got rid of the phrase congenital dislocation of the hip, because this problem is not just about, are you born with a dodgy hip, right? It's about development, and development starts in utero and continues in childhood. So we want to focus everyone's attention that it's not just about something at birth or just in the baby. Now, in this relationship between the femur and the pelvis, initially those structures are predominantly cartilaginous and are very susceptible, if you like, to molding, and that can be your friend or your enemy. And if you've got things in the wrong position and the wrong forces, it will have a negative effect on development. So we're basically talking about this concept about development, not just congenital. On that picture down the bottom where it says infant and there's those green lines, that's trying to suggest that there is a force, if you like, mechanical forces lined up nicely that create the best environment, just like any relationship, creating the best environment for 2 things to grow, if you like, to love each other. Now, in dysplastic hip, the word dysplasia is a Greek word. Dys means the negative connotation of something. And I love the idea of dysfunctional, you see, because I could come from a functional family, but the minute I tell you I'm from a dysfunctional family, I'm not really. But if I tell you that, you get the meaning of the word dys. It's the negative connotation. And dysplasia means a mold or a shape. Neoplasia is a great example, means a new formation or shape. So dysplasia means the negative, the abnormal, the wrong shape. And in dysplasia of the hip, generally, there's going to be two main concepts: that something's in the wrong relationship. So between this femur and acetabulum, they're in the wrong position, the wrong location, and there's a wrong shape component. And the more they're in the wrong position, the more likely they are to be the wrong shape. And when they're in the wrong shape, they can't be in the right position. So these two concepts are linked. So you see on the pictures here, we've got this sort of subluxation of the newborn's femoral head. And then later on, the cartilage of the femur hasn't developed properly. We haven't got the best pictures here because the acetabulum also would not develop, which these pictures don't show. But if I flip between the two, you'll see that, if you like, that wrong position has a consequence on wrong shape. And then wrong shape, obviously, as you get older, will catch up with you. And that's really why we're going to treat hip dysplasia, because left to itself, it will lead to a negative long-term outcome for the hip joint. So back to you, Mel.
Just one more Slido question. Won't be a sec while I switch around.
You can see I've left all the technical stuff to Millie because she's younger than me.
Okay. Now I need to share this. So my next question is, what are the risk factors for DDH? What do you know already? Yep. Excellent. Breach, yes. Family history, multiple births, firstborn, female.
And some people have put breech birth and other people have put breech presentation, and we'll talk about that as well.
Over 4 kilos, yeah.
P1 as an orthopedic surgeon means nothing to me. I presume it's the first child. I'm classic orthopedic surgeon.
All right, we've got 2 more people typing and then we'll keep going. Mobility incorrect, swaddling girl. Yep. Breach in 3rd trimester, use of forceps. Is that forceps?
Yeah. All right.
All right. We'll switch around. Thanks, everyone.
We love the interaction. Thank you.
Let's get back to our presentation. All right. So yes, that was a good lead into and good test for everyone here tonight. So yes, 2 big ones are family history of DDH, and most recently it sort of has been your, I guess, immediate family, your siblings and parents, but it can also be grandparents and first cousins, and extended family. That's family history is important for DDH. Breech position or birth. So after 32 weeks gestation, if the baby is in breech position, then we would consider that at risk of DDH. Yeah,
and we talk about breech position because many obstetricians will go for cesarean section, and many mums will go for the section. So they don't necessarily have a breech birth. Some do, but many kids that are breech position are born by section.
Yep. And this picture here is a frank breech position, which is the highest risk of DDH, given the hyperextension of the hips and more likely to have hip instability. The next risk factors are female, but not necessarily on its own, and those related to intrauterine restriction that some people got through. So firstborn, oleohydramnios is correct, where there's reduced fluid. Positional talipes. So not all positional talipes have a link to DDH. So it's more the calcaneovalgus type, which is where the forefoot sits dorsiflexed, hyperdorsiflexed up towards the shin. Otherwise, there's also metatarsus adductus that are the most linked to DDH. Also twins and high birth weight greater than 4 kilos. The other thing that also has a link, other packaging conditions, is congenital muscular torticollis and some neuromuscular conditions. So a bit about some of the numbers. So if there's no risk factors, 19 out of 1,000 births of girls have DDH. For boys, 4 out of 1,000. And for family history of DDH, it is higher in the girls. So 44 out of 1,000 births, girls will have DDH, with those with a family history, versus 9 out of 1,000 for boys with a family history. So it's just not fair for us girls. And for breech position, so again, like I said about that 32 weeks gestation after 32 weeks, so breech is really high in girls. It's 120 out of 1,000 for girls versus 26 out of 1,000 for boys. The left hip is most commonly affected, 65% of the time, and usually bilateral 20% of the time, and hence 80% are unilateral. So we also do screen babies that have congenital talipes equinovarus or clubfoot, or also known as fixed talipes, but the evidence for that is sort of mixed. So I think anecdotally we do tend to screen those babies.
Yeah, we say screen, we'll come on to that. We screen all babies,
Yeah.
but we're talking there about whether we use ultrasound, and we'll talk a bit more about that.
But we'll come back to that next. So I guess that brings us into screening. So this is screening overview. So why do we screen? So we screen because I guess DDH is asymptomatic. It's not painful. A baby's not going to be crying or upset or show abnormal behaviours if they have DDH. And early intervention really affects outcome. So a delay in management of severe DDH will take longer to treat and may then progress and worsen and likely to need surgery. Also, it accounts for 25% of hip replacements in under 40-year-olds. And Chris also sees adults, so I can vouch for some of that. And who do we screen? So we screen everyone, all newborn children. It's just we decide we don't universally hip ultrasound, which we will talk about along the way, and we'll go through the screening process and the logistics. When do we screen, at what time points, and how do we screen? So we're going to break down multiple time points, and for each time point we're going to talk about when it's done, who is the baby's assessed by, what test we do, what to do if the screening is abnormal, and tip for the GP. But first we see babies at birth. They're assessed by the birth unit, the maternity ward, and usually they have a discharge check, most likely by the midwife and or by the paediatrician, and that test is usually manual. So we'll go through the manual assessments at birth. So if the manual screening is abnormal at birth, that would be the case where the baby's referred directly to a local DDH clinic. So that would be from our Western Health, that would be from our maternity ward directly to me. And so the tip for the GP, this usually doesn't involve you. This would be directly from the maternity service.
Yeah. So if you referred it as a GP, it wouldn't be wrong per se, but we'd be wondering why it was coming from you. Maybe it was a home birth or something. Maybe you are the person who delivers the child. But typically we wouldn't expect this to be coming through the GP from our perspective.
So we'd usually see those referrals for our service that would come through from our newborn services, our paediatricians, and those sorts of doctors that would send the referrals at that age.
And that would be with instability. So they detected instability, primarily familial. I'll talk about instability.
So that brings us into our first assessment, which is hip instability at birth, the primary thing we're looking at. So our first assessment, and this is a Victorian Paediatric Orthopaedic Network video. Baby's nice and calm and relaxed. They're about to perform the Barlow test. So we've got the left hand there stabilizing the pelvis and the right hand here flexing the hip up to 90 degrees, gently adducting the hip. And what we're trying to do here is we're trying to dislocate or sublux the femoral head. We're trying to feel if there's any instability there. And what you may feel if you're doing this assessment is you may feel like a gentle sliding movement versus a stable hip that you would feel a firm and you don't really feel movement. So the baby should be very relaxed to do this assessment with their pelvis nice and neutral, baby relaxed, lighting dimmed, family assisting with calming the baby. If you're having a screaming, inconsolable child, you won't be able to feel the baby's going to be tensing their legs and they're not going to be relaxed enough to perform the assessment. And these assessments of hip instability, the next one we're going to go through is ortolani, are usually the most sensitive from birth to around 3 months of age. And we'll keep talking about
Someone mentioned in their Slido swaddling. And of course, you can see in this case that adduction of the hips is the position most likely to push it out of joint. And so we don't like that idea of babies having their legs pulled close together, being wrapped all tightly for the hips. And as you'll see in a minute from the ortolani, abduction is a good position, if you like, for hips being relocated. And so when we come on to bracing, you'll see that bracing basically mirrors that abduction.
That's right. So the next one is the ortolani assessment. Oh, yeah. So same, baby also needs to be relaxed. And this assessment is looking at a hip that is already dislocated. And you can see when the hips are flexed, one leg is shorter than the other, which we'll go through in our next assessments. And that's because the hip is out of the joint. And this assessment looks to see if the dislocated hip is able to be reduced or put back into the hip joint. So this is abducting the hip and you're lifting up through your fingers where your fingers are palpating the greater trochanter and reducing that femoral head back into the acetabulum. So usually we would feel either a gliding back into the joint as the femoral head glides over the posterior lip of the acetabulum, or you might feel a clunk back in. So often we get a lot of referrals for hip clicks, but a hip click, this isn't usually the case. When you're feeling a hip reduce, you don't usually feel a click. You would feel either feel a clunk or you would just feel a gliding sensation.
Yeah, it gets called often the clicky hip test, but people talk about clicks and clunks and all that. But really what you're doing is saying, I think this is unstable. I don't think that the femur is staying in the acetabulum. Either it's dislocated and I can put it back in, or it's in and I can put it out. That's really what this test is about, instability.
That's right.
Yep.
So we've looked at hip instability. We also want to look at hip asymmetry. So we want to look, is there reduced hip abduction on one side or both sides? Is there a shorter leg with an extra skin crease or change in Galeazzi, so that leg length discrepancy? We also want to look at the posture of the baby for these things specifically. So the posture may be that the baby sits with their leg more adducted across their body. And as Chris mentioned, this can allow the hip to be more likely to be dislocated. And sometimes this is described as a windswept posture. And it can come in conjunction with those packaging conditions, like the congenital muscular torticollis, the positional talipes, so the really strong head turn preference. And often the baby in utero has their hip up against the mother's sacrum, and it's usually their left hip, and it's causing their left hip to be more adducted. And beware of relying on asymmetry, because DDH may be bilateral and you may not be able to differentiate, for example, between two dislocated hips. So looking at asymmetry, the next thing we want to look at is hip abduction. So you can see in both of these pictures, there is a difference in the hip abduction. So we'd normally flex the baby's hips up to 90 degrees and then abduct the legs. So on the left, a normal range for hip abduction is usually around 70 to 90 degrees. So in this baby, well, in both sort of babies in the picture, where the range is around that 45 to 50 degrees, that's quite tight. And we'd be concerned about a possible dislocation. And when the hip abduction is quite tight, it affects the thigh and groin creases. So this picture on the right is actually from a journal article where the baby is in theatre and under anaesthetic. So that's their full passive range of motion while the baby's asleep. And you can see that really thickened groin crease of their right hip that has that reduced hip abduction range of motion compared to their left hip, this hip. So you can see that thickening through here. And this hip abduction assessment is more sensitive for those older babies where the instability testing isn't as sensitive. So then we would look at our groin creases and thigh creases. So our proximal creases we would look at in prone and in supine, and the asymmetry of the groin creases is something that would be more likely to be related to a dislocated hip, versus the thigh creases, which are often a softer sign. They're often asymmetrical and not something we're usually as concerned about. We're more concerned about the groin creases, but we get tons and tons and tons of referrals through our hip clinic of babies that have had their maternal child health nurse checks. The maternal child health nurse has noted the thigh crease asymmetry, referred them back to the GP to have a hip scan, and they may or may not have hip dysplasia.
Yeah, if you think about the hips dislocated, like we showed on that illustration, the leg is shorter, if you like, because the hip is back. So like one of those concertina, those squeezy boxes, the soft tissues have redundancy, hence you get the extra crease. So in many ways, if you get a unilateral dislocated hip, you should have an extra crease, if you like, because the soft tissue redundancy. But the converse doesn't work, that if you've got an extra crease, it's because of a dislocated hip. And actually in most of our referrals where we get, please see this kid with an extra crease, even if the ultrasound says, oh, it's slightly dysplastic, that dysplasia is probably not the cause of the crease because it's not dislocated. And so as a GP, you are in a little bit of a challenge when someone brings the kid with an extra crease. And the answer is to do some imaging and see if you've got dysplasia, not to just refer it because there's an extra crease. And we'll talk a little bit more about that later, about the referral pathway.
And then the next assessment, so this is the Galeazzi or modified Galeazzi assessment, where you would flex both hips up to that 90 degrees, and you're looking for the shortened leg. So you're looking for asymmetry, and that asymmetry might be subtle, might not be as evident as in both of these pictures, where the hip is clearly dislocated, hence the shorter leg is the dislocated hip, because the hip will be posteriorly dislocated, and hence that shortened femur.
And in some ways, you're on a hiding to nothing as a GP. If someone raises a concern, and I know you could examine it and say, no, I don't agree with your clinical findings, there is no short leg or whatever, but almost if somebody raises a question based on any aspect of manual testing, your safest bet in these babies is to do an ultrasound, because you can't really be criticized for doing that. You're taking seriously somebody else's observation, even if you don't agree with it. That would be one of my observations here.
Yep. So our next time point would be our 6 to 8 week mark. So usually here in Victoria, the maternal child health nurse tends to have an 8-week check. And at that point, we would recommend manual assessment of all babies. But at this point, manual and ultrasound assessment for those with risk factors. So those with the positive family history, those that are breech, and those that have any of the other risk factors that we mentioned. But the family history and the breech, those are the non-negotiable. They should have a hip ultrasound.
Yeah. So in the journey of the child, this is really their second screening process. The first one is at birth. The second one is about this time. And the only difference between the two is that, yes, they all get manual But in this country, we've decided that we'll do ultrasound for these 2 risk factors. Now, there are other countries that do universal ultrasound screening, and the advantage of that is it's like you've got a safety net that's closer. The holes in the net are smaller, so less things fall through the safety net. But the challenge with universal ultrasound screening is over-calling hip dysplasia and maybe over-treating. And at the moment in this country, we don't universally ultrasound. And it may be the only way that would change would be if, I suppose, doctors lobbied the government to do it. I don't think the government off their own back are going to do it. They're going to do it if doctors put the argument to them. So that might change in Australia. But at the moment, this is this hybrid model of manual as the baseline, but doing ultrasound if you have these risk factors, because we've already seen if you have these 2 risk factors, you have a much higher chance of having hip dysplasia.
And we also take into account in terms of the manual assessments that those that work in, say, maternity wards, such as the midwives, the paediatricians, the neonatologists probably feel a bit more skilled and more comfortable perhaps in doing some of those instability assessments, whereas GPs may feel less confident and less sensitive in those assessments. But there are some more learning packages that you can do in terms of those videos that we've provided that we can give you some links to. Anyway, I'll go on.
Yeah, we're going to take this opportunity to talk about ultrasound now. This is the typical ultrasound image that you might see or you might get. I think one way to understand ultrasound is to realize this has been taken in a different orientation to an X-ray. If we were to compare this ultrasound with a baby X-ray, first of all, you actually understand why we do the ultrasound, because the femoral head is not apparent on the X-ray. You can't contrast it. So the X-ray is useless, really, or near to useless at this age. The ultrasound is important, and that's good because ultrasound doesn't come with radiation, right? So one way you can do is take that ultrasound and rotate it around. And when you rotate it around, you've sort of got the same orientation as the X-ray. And so this yellow line here, that's the bony acetabulum, not the cartilaginous, but the bony. And then this here is the ossified metaphysis of the femur. So at this age, the femoral head, or the capital femoral epiphysis, has not yet ossified. And that's where ultrasound is king, because it can show cartilage, whereas the X-ray can't contrast cartilage from the other soft tissues. So on the ultrasound, that's where the femoral head is, even though on the X-ray, you don't know where it is. Now, a guy called Graf did some work on this, trying to work out what was normal and what was abnormal. Remember, we said dysplasia. Dys is the negative connotation. So dysplasia means it's the wrong shape. So how do you quantify that? And Graf did this work whereby this is the orientation of the ultrasound. He said you can draw a line along the ilium. That's like a baseline. And then you can have a look how much of your femoral head is within that baseline, if you like, how much what we call coverage. So you might have an ultrasound report saying 58% coverage. And obviously, the more coverage, the better, because it means the deeper the acetabulum and the more the femoral head is sitting in it. Remember, I said it's all about that relationship between the two. And the less coverage, the more likely it is that the hip's dislocated. So that was coverage. And then the next thing Graf did was talked about, you know, if you like, the depth of the acetabulum by an angle. And we call this the alpha angle. And what you really want with your alpha angle is for it to be big, because the bigger the alpha angle, if you like, the deeper the acetabulum. And if it's deeper, it means it's likely to be being shaped by a femoral head that's sitting properly in it. When the femoral head's not properly in it, the acetabulum is more likely to be shallow because you've not got this relationship between the two molding and shaping each other. And then the third line was that beta angle, which we probably isn't so important. And you really want a small beta, because the further the hip is out, the further it's pushed that cartilaginous roof out. And so this is what basically Graf came up with, something like this. And you'll see loads of these tables on the internet. And you can see in a graph 1, that's a normal hip. So what we definitely don't want is a referral saying, please see this kid with a normal groin crease or with a family history, but someone's done an ultrasound scan and it's a graph 1, because the ultrasound scan means a normal hip. Now, I'm not saying you can't recheck that another time, but if it's a graph 1, please don't refer it as hip dysplasia, because it'd be like testing a blood glucose and saying it's 3, they've got diabetes. It would make no sense. In this, however, you have to remember that in this first 3 months of life, these figures here in the graph 2A and B could mean dysplasia but could mean that the hip is still a bit immature and still getting better on its own. So one of the challenges with ultrasound, if you like, universally would be that in this graph 2A, 2B, do you overtreat hips that would have normalized without bracing? And this is an area where there is some confusion amongst our referrals, and we'll come back to this in a minute. So have a little look at this ultrasound of a kid, a right and left hip. If I just outline some of the key areas, the solid white line is the, if you like, the bony acetabulum and the edge of the acetabulum, and the round dotted line is the femoral head. You can see on the right, the femoral head sitting inside and it's fairly well covered, but on the left, that hip is dislocated. And so these are the things that we then are going to intervene with when we come up with a hip that's dysplastic, and particularly if it's dislocated. Back to you, Mel.
Thanks, Chris. So the pros for ultrasound. So it's safe for use in children up to 6 to 8 months. So our sonographers can try to get them up until about 9 months here, and sometimes at other services, such as at the children's, they might be up to 10 months and later. It visualizes the cartilage of the hip that Chris spoke about. It identifies a dysplastic hip, and there's no radiation involved in an ultrasound because it is just sound waves. The cons, it is operator dependent. So a lot of our sonographers in our clinic are quite highly trained. They get a large volume of hips coming through our clinics, so they get used to doing many hip ultrasounds. Whereas in the community, it can be a bit more challenging for sonographers because they are needing to specialize in many different musculoskeletal ultrasounds, so they don't get quite the volume, and the reliability does vary based on skill and experience. The other thing is, as children get older, the bony ossification centers start to develop, and those bony ossification centers start to obscure the landmarks. So that's when we would switch to X-ray. And as we sort of mentioned before, we don't universally ultrasound here in Australia because of the number of patients that it would pick up that may have improved on their own, and the large cost associated with doing an ultrasound for every baby born.
With the comment about the operator dependent, I work at the Children's Hospital as well as here, and we've been wondering whether in the community, because at the moment you could probably go into any imaging place and have an ultrasound done, whether we should be looking to nominate almost sort of centres of more expertise. And my colleagues at the Children's are currently doing some research into the quality of ultrasounds, because if you're making a decision based on an image, you first of all need to ask yourself, is that image of diagnostic quality? And so that's some of our work at the moment has been trying to improve the whole ultrasound and also ultrasound reporting, because quite often we've had referrals where the GP has rightly referred based on the results of the report of the ultrasound, but when we've looked at the ultrasound, we have not agreed with what the radiologist has suggested. So that's a whole other area, and we'll touch on that a bit later too.
So that gets us back to, so we've screened our baby at 6 to 8 weeks. They've had a manual assessment. They've had risk factors because, and had a hip ultrasound. And then what if the screening is abnormal? So if the manual testing is abnormal, get an ultrasound. If the ultrasound is abnormal, either repeat or refer.
Yeah,
so,
we put that in inverted commas because abnormal comes down. Sorry, Millie, I've interrupted you, but this abnormal is really comes back to that work by Graf, which is it may actually be immature. And so often we'll have a letter from a GP saying, please see this kid with hip dysplasia. When we look at the ultrasound report, the radiographer has actually said, recommend repeat in 6 weeks. And so for us, we'd reject that referral because the radiographer has already said this could be an immature hip, not DDH. And so that's where maybe some of you might get confused, or why did they reject it? Well, it's because the radiographer has already given the clue that this might not be hip dysplasia. Sorry.
Yep, that's all right. So the things tip for GP, refer when there's confirmed DDH. Oh, sorry, I should go back. I skipped that. At 3 months, assessed by the maternal child health nurse at the 12-week mark, which test manual for all children. So interval ultrasound. So baby may have a repeat hip ultrasound if the previous was immature, or if they've had delay in picking up the risk factors and this is their first scan, they have the ultrasound now, or their first manual assessment, they have that now. And again, if screening is abnormal manual tests, get an ultrasound. If abnormal ultrasound, refer or possibly repeat the scan again. And then refer to us only if there's confirmed DDH on that ultrasound scan.
On the bit there where we put what to do if the screening's abnormal, and the answer is you've got an abnormal ultrasound, we switched the order around there to refer as the first, should be the first thought, because this child's now 3 months, so they should be past the physiological, if you like, that immaturity stage. But the reason I put possibly interval repeat is if you've had a couple of ultrasounds already and each one's saying the hip is getting better with no bracing, then the chances are we wouldn't brace ourselves. So you could, in that situation, rather than referring it to us, repeat the ultrasound again. Because all of those ones where you're repeating the ultrasound, you've got to remember the hip is in joint. These are not the dislocated ones. These are not the bond or obvious must be treated, get on with it. These are the subtle differences that really are not going to come to great harm if you just bide your time and work out for sure if it is like how dysplastic the hip is and what's happening on its own. But generally by 3 months, if it's saying this hip is dysplastic, we want to be seeing it.
Yep. And at 3 months, we're past usually that immaturity stage. So we'll know at that over 3 months if it is DDH or it is not. Next step, at 6 months, they're usually assessed by the maternal child health nurse and or GP. That screening again is manual, and this time the instability assessments aren't sensitive, so we'd be looking at those asymmetry assessments, so that hip abduction, the leg length discrepancy decreases. So what do we do if the screening is abnormal? If the manual test is abnormal, get an ultrasound. 6 months in a lot of literature, I guess, is the cusp between ultrasound and X-ray, but given the benefit of no radiation for an ultrasound, we would always say at least try the ultrasound at 6 months. And if the report comes back that they were too old, they have too much bone, then refer for an X-ray. And
quite often, some of the imaging places will use their initiative and they'll go on and do the X-ray. So they'll say ultrasound done, Civic Centre too advanced for meaningful interpretation. We did an X-ray instead. And so that then sometimes they will make that decision for you, but we would still encourage, try and eke out ultrasound for as long as you can, if you like.
Although those community sonographers may be less experienced in the older children. And if an abnormal ultrasound at that age, refer. And tip for the GP, only refer confirmed DDH. At 12 months, again assessed by the maternal child health nurse, manual assessments looking at asymmetry. And here, if screening is abnormal, an abnormal manual test, get an X-ray. An abnormal X-ray, then we would refer. And if that imaging confirms DDH on the report, then you would refer to us. And then Chris is going to talk about X-rays.
Yeah, and as you get nearer to the 12 months, what's going to happen is you're not going to be seeing the kid referred to you by the person who did the screening anymore. You're going to find that granny or someone else noticed the crease and comes to see you. So you'll start, the older the child gets, the more it's going to deviate from screening to, oh, somebody noticed something. And then you've got this opportunity, if you like, to pick up the ones that have gone through the safety net already with imaging. So let's have a look at X-ray. This is a 15-day-old female. This X-ray was taken because the kid came with gastro to ED. So we didn't X-ray this kid for their hips. This is an abdominal X-ray, but I've used it because it's a nice teaching case. And what you can see there is the bony acetabulum and the ossified femoral shaft and metaphysis, but you've got no idea where the cartilaginous acetabulum or femoral head, well, you sort of know where they roughly are, but you've got no idea about their shape because you can't contrast between them and the other soft tissues. Hence why we do the ultrasound. But by the time you get into 6 or 8 months or somewhere around there, the capital femoral epiphysis has started to ossify, and then you can start to make some head nor tail of it. Now, while I'm on the subject of ossification, we have some referrals because the radiologist has said that one is smaller than the other, right? And then there's this big concern of they got hip dysplasia, but often they say the hip's the right shape. Right, all the angles are correct. The hip's the right shape, but one ossification center is slightly smaller than the other. That can be physiological, and again, does not mean hip dysplasia. And when we get those referrals, what we like to do is log on to whoever did the X-ray and look at it for ourselves and see if we think it's dysplastic or not. And what we don't have is very good ways to communicate that back to the GP. We tend to reject the referral, but we like to say, look, it wasn't a bad referral, but this is the reason we rejected it. So I think that's always room for improvement for us when we do our triaging of how we communicate with you why we rejected what we rejected. So it is true that a delayed ossification goes along with a dysplastic hip, but if you haven't got a dysplastic hip, the slightly smaller difference doesn't really mean anything. And if in doubt, you can always repeat the imaging later on, because remember, it's not a dislocated hip. It's this debate about how dys is the dysplasia. So here's the 8-month-old female, and historically we used to draw, sorry, there's the ossification center. We used to draw a Hilgenreiner's line and a Perkins line, and we would look which quadrant the ossified femoral head was in. Is it in the inferomedial quadrant, which it is? We don't tend too much now to do Perkins line, but we tend to go by acetabular angle, and that's this line here. And we're looking normally for an acetabular index or an acetabular angle by the age of 1 year of age. That's probably, well, it's under 30 degrees, like maybe under 28 degrees, somewhere around there. And another problem that we've had recently is our radiologists have been saying maybe 26 degrees or 24 degrees is the cutoff. So we end up with reports saying, you know, the hip's dysplastic because the angle's wrong. But when we look at it, we don't agree with them. And then we reject that referral, but also need to communicate to the GP, hey, you didn't do anything wrong with your referral. It's just we don't consider this dysplastic. And again, in those cases, we can always repeat the X-ray if needs be with an interval of time to check. The other thing is called Shenton's line or Shenton's arc. And that's basically you draw this line on the inferior sort of medial part of the femur and the pubic ramus, and that should sort of link up to make an arc. And you'll see in a minute, this is a dislocated hip. The ossification centers haven't appeared on either side yet at 8 months. And if we draw Hilgenreiner's line, you can straight away see that on the right, that top of the femur is in completely the wrong quadrant. And then if you look at Shenton's, you see that complete break. This is a dislocation. It's in the wrong location. It's in the wrong position. The relationship is wrong. And it shouldn't surprise you that our job is to put it in the right position. I joke about this. We're like the married at first sight or the marriage counselors. Our job is to restore a relationship. Okay, Mel.
All right. And this is just a summary slide of the ideal pathway that we just spoke about for each time point. So feel free to grab a quick photo of that if you need to. Otherwise, we'll move on. So that's the ideal pathway. So the non-ideal pathway is those children that have slipped through the cracks. So what if their screening journey has been deficient? So sometimes we have children, especially in our area in the west of Melbourne, we have quite challenging socioeconomic status of patients, and it's a big growth corridor where we are. And often there can be multiple factors that families haven't engaged with maternal child health nurses. They may not have English as a first language. They have low health literacy. They've missed their appointments, or they didn't know or were never told about risk factors in order to have screening. So often many may not have had screening at all. So what if any of these patients come to you as a GP? We want you to screen manually. All of the assessments we've spoken about at any time point, the manual assessment. So if they come to you at 4 months, 5 months, 8 months, screen manually and do imaging if you detect an abnormality or if they have risk factors that they've never had imaged, and depending on their age, ultrasound versus X-ray. So in DDH, your role as a GP is to detect the DDH via the screening pathway and refer on to the local DDH service. And our role is the management of the DDH and communication back to the GP regarding the progress. So our DDH clinic probably has changed slightly. We did used to have patients that we would screen, and within the last 2 years, this process has changed and we now are a treatment only clinic. So that's why we're sort of providing this update as well, that we're not accepting those screening referrals anymore. So in your referral to us, what we want to know is, how did the diagnosis come about? So who was concerned and why? Was that the maternal child health nurse? Was it a parent? Was it yourself? At what point was someone concerned? We also want to know about the birth history. So we want to know how many weeks gestation was the baby, how they were delivered, the birth weight, and if they were breech position, and any other factors that may be concerning as part of their birth history. What was detected on screening, including an imaging report. So whether DDH was detected at the birth unit, that instability, or versus the maternal child health nurse checks on their manual screening and subsequently referred for imaging. And often someone has a concern outside the screening process. So it might be a parent that knows about or has spoken to someone else about the asymmetric creases, and then that's brought about concern. It may be a healthcare professional such as a physio or other professional that's noted something on their own manual assessments. It may be a lack of faith in the screening process. So there may be, for example, a strong family history, but being told that everything's normal. It may be delayed gross motor skills, such as a 14-month-old that's not walking and then is referred to us, but in actual fact, not walking at 14 months is within the normal range. But someone's brought about that concern, or there may be concern brought up by somebody that there's asymmetry, whether that be in creases, whether that be in leg kicking, or whether that be the child is old enough that they're walking and they have a limp.
Yeah, because the child will have been imaged, and most of that imaging is going to be arranged by the GP, but we want to know, why did you do the image? Not just please see image shows, but why was it the whole journey came about to do the image in the first place? Because if we log on and look at that image and think, oh, you know, we can better triage it by knowing the background to how it came about that the imaging was done.
Because if the imaging was, if we're receiving a referral for a 9-month-old baby and they have DDH on their x-ray, but in actual fact they were born breech and never screened, that would be important for us to take on that patient as soon as we could. So some of the reasons we might reject a referral is there's no diagnosed DDH. So perhaps that screening hip ultrasound or x-ray is actually normal. If there's not been any imaging done, so you're referring the patient for asymmetric skin creases or family history, but there hasn't actually been any imaging to do the screening, or the imaging report has not been attached to the referral, or as we spoke about, the immaturity versus DDH.
And it's the imaging report is not that we don't believe you, and sometimes there's a bit of a copy and paste of the results, but we want to, some of these to help us triage it, we really want to log on and look at, because sometimes we are going to question what the radiologist has said. Sometimes we want to triage it, but we might say, hey, we don't want to see this for 6 months because this is so near to normal, and we don't think we're going to brace it, say they're 1 year of age. All we want is an interval x-ray. And so those things are really helpful for us. And, you know, sometimes we'll get a referral saying, you know, please see this child, mum concerned, positive family history, but all the imaging's normal. Well, that means they've got a family history. It doesn't mean they've got the disease. So these are some of the challenges why we might reject our referrals. And please apologize if we're almost like bombarding you with all the bad referrals. It's not like that at all. We get the vast majority of referrals are good. It's just in our triaging system at the West, and to a degree at the Children's, we don't have a good way of feeding back to you what we feel about why we rejected the referral, and which often is just a case of, hey, we feel you can manage this either by doing the imaging again, or you can manage it by, as in doing the imaging again, as the radiologist said, or by repeating the x-ray, say in a year's time, if we think, hey, it all looks normal, but we gather there's concern, so we could repeat the x-ray in a year or something like that.
So that brings us to the DDH services that are in Victoria. So our metropolitan services are the Royal Children's Hospital, Monash Children's Hospital down in the southeast, and here in the west, Western Health, Joan Kirner. More our regional centres, we've got Barwon Health, which is down in Geelong, and there's also a hip clinic at Ballarat, and Bendigo Health as well. So this is our hospital, Joan Kirner Women's and Children's Hospital. It was built and opened back, well, it was opened back in May 2019 and named after Victoria's first female premier. Joan Kirner, we have newborn services with a neonatal intensive care unit, as well as special care nursery, a children's ward, maternity ward, and specialist outpatient services. such as our advanced practice and orthopedics. And back in 2020/2021, there were over 6,600 babies that were delivered at Joan Kirner, which was a 17% increase from when the facility opened in 2019. And unfortunately, I don't have the numbers for the following year, but I'd be interested to know. This is a photo of our DDH team. So there's a couple of advanced practice physios. We've got a few sonographers. We've got Liam, our orthotist, and also Ben Johnson, one of our orthopedic surgeons. Unfortunately, I didn't get a photo of Chris on this day.
Okay,
and here's our team. So Chris and Ben are the orthopedic surgeons. Advanced practice physiotherapists, we've got myself, Melinda and Julianne, and our orthotists who work externally through Opal, Liam and Emma. And then we've got lots of sonographers through our radiology department. My role as an advanced practice physiotherapist, so I'm working in the role of paediatric orthopedics, still under physiotherapy. DDH was historically managed by orthopedics, but for over 10 years, DDH clinics have been running at Western Health. Being advanced practice physiotherapists, you do require specialist orthopedic training, which is postgraduate, and also extensive internal credentialing systems, and it's quite competitive. So our DDH service at Western Health is co-located with hip ultrasound. So we have an advanced practice physiotherapist and a sonographer working in the same room. The sonographer would do the hip ultrasound and the physio would do their clinical examination and then make decisions based on both of those. And then we have orthotics on site to fit and review the brace now same day. And orthopedics is around the same day to oversee any complex cases and consult. This is one of the resources that we would use to provide to families that have been diagnosed with DDH on our ultrasound. So typically, if you do a referral to our clinic, even though you may have done an ultrasound in the community, we would usually repeat it on the same day. Often there is a time lag between their hip ultrasound and ours, so where we may see some improvement or change. And this is a Victorian Paediatric Orthopaedic Network handout that we would provide the parents. So in terms of the management, so in terms of bracing, our idea is that we want to have that femoral head sitting really nicely within that acetabulum. And the best way of reducing that femoral head is using that frog leg position, which is the closed packed position. It optimizes that relationship and the forces to allow the femoral head to develop and the acetabulum, the cup, to deepen and sharpen. And we'll continue usually to brace in that position until there's normal development of the hip and acetabulum. So that would mean we'll keep bracing until we see a normal ultrasound or a normal x-ray. And based on the evidence, bracing is very effective and it is considered the gold standard in terms of treatment. So there's a few different braces that are used, and some different services use different braces based on their orthopedic department preference. We do tend to use the Pavlik harness a bit less, but have used it quite a bit in the past. It's a soft dynamic harness. It's commonly used for babies with dislocated hips and can be worn full time, and nappies can be changed around the brace. The other brace that we tend to use more commonly and our orthotists make and apply fit same day, as do the Children's Hospital, is the Dennis Brown brace. It can be worn full time. It's a rigid brace that keeps the babies in this frog leg abducted position. So this is that closed packed position to allow that acetabulum to deepen. And babies can be cared for around the brace. This brace is the rhino brace or hippo brace. It's a much larger brace. It's a more rigid brace, but it is designed for children that are a bit older. Children can learn to crawl, sit, pull to stand, even walk in the brace if they're older and being braced. And I have a couple of case studies from a few recent babies that we've seen in the hip ultrasound clinic. So we had a referral for a 13-week-old baby we call Ella, not her real name. She was referred from the GP with DDH on an external hip ultrasound scan. She was screened due to asymmetric creases and positional talipes picked up by the maternal child health nurse. Her birth history was...
Which, Millie, to interrupt, that's not really part of our classic screening thing. But again, when somebody raises a concern, we don't mind the child having ultrasound.
That's right. So the birth history was normal term, normal delivery, normal birth weight. In terms of the risk factors for the baby, they were not breached. There was no family history. Otherwise, it was being firstborn and female. On the objective examination, it was all normal other than the asymmetric creases. And then our hip ultrasound revealed mild left DDH and mild to moderate right DDH. So this hip is shallower compared to this side, which is more a bit rounded. So I've decided to brace the baby in a Dennis Brown brace for 23 out of 24 hours and review with a repeat hip ultrasound in 6 weeks. So at the 6-week review, baby Ella is now 4 months of age. Repeat hip examination was normal, and repeat scan just revealed that there was some residual rounding on the right. So it was nearly normal. So we weaned down to 22 hours in the Dennis Brown brace. DB is Dennis Brown.
And one of our challenges, and we're looking into it at the children's, is whether this rounding, what on the ultrasound actually constitutes dysplasia. What we think is coverage and alpha angle are really important, and these other subtle things, they may not. This is an area where we need to do research in how much, as I said before, how is the dysplasia.
And then at our next review, which was 13 weeks, so Ella was 5.5 months old, normal objective examination at that point. The ultrasound was normal, so we decided to cease bracing and follow up with an X-ray in 4 months' time. And my second case, baby Sally, was referred to us at quite young age, at 10 days of age. She was referred from Werribee Mercy Hospital with left dislocated hip at birth, normal birth history, term, normal delivery, birth weight 2.9 kilograms, not breech, only risk factor was being female. On objective exam, did have full hip abduction range of motion, but positive left examination, the hip was dislocated, and positive left ortolani, so I was able to reduce the femoral head back into the joint, and the right hip was stable. So you can see this is similar to Chris's scan. This is the very shallow acetabulum, and the hip is sitting dislocated. The hip ultrasound revealed an immature right hip, as the baby was only 10 days old, and dislocated left hip. So we referred for a Dennis Brown brace to be worn full time and follow up in a week. At the 1 week...
Why 1 week, Millie?
Yep, I'll go into that. So at the 1 week review, my plan was to review in the brace and do an ultrasound to see if that femoral head had actually gone back in and was staying in. So we did a ultrasound in the brace. So this is this picture here in the brace. And you can see it is harder to scan for the sonographers in the brace because the landmarks are slightly different. But this is that ilium and acetabulum here, and the femoral head is sitting within the joint. And at that 1 week mark, that is our goal for a dislocated hip. Given it was quite complex, quite unstable, the hip, I brought them back at 2 weeks to review them with another scan in the brace. And if the hip is stable in the brace, out of the brace. And at that point, out of the brace, the baby's left hip was in the joint and was stable. So baby continued bracing full time. Then at our 6 week review, the hip had improved, the left hip had improved quite significantly, now mild rather than severe DDH. And we reduced the DB, the Dennis Brown brace, down to 23 hours. Then another 6 weeks later, we reviewed, so that 12 weeks, baby's 14 weeks of age, some very mild residual rounding. So I weaned a little bit more in the Dennis Brown brace. And then at 18 weeks, there was still some persistent rounding. And then at 6 months, a 6-month review, the hip was normal and bracing was ceased. And we referred for follow-up X-ray in 4 months. So often with bracing, we have a lot of parental concerns, a lot of parental anxiety that we have to negate. How long will my child be in a brace for? And usually the answer would be a minimum of 12 weeks. And often for those dislocated, unstable hips, and maybe up to 6 months. can a baby have a bath? They can have a bath if they are allowed out. So if that baby with the dislocated hip that was in the brace full time couldn't have a bath because they were allowed no time out of the brace, but as soon as we gave them more time, the hip was stable, they could have a bath. Will it delay their gross motor milestones? Sometimes it can cause a mild delay in gross motor milestones, but usually it's very, the children catch up and they still walk within the normal range, but it is a very common question. And often if there are gross motor delays for a child, there often is some other neurological concern or global developmental delays going on as well. Will my child be able to walk? Yes, that's a name of the treatment. Will my child have ongoing problems with their hip? Not usually, but that's where we would do ongoing monitoring of the hips, which we'll go into. And does my child need surgery? Typically, no. But if our bracing has been unsuccessful, then maybe. And also, if the parents have to present to the GP with a lot of questions, a lot will be, or if you, I guess your role would be, you've made the diagnosis that the baby has DDH, you may get a lot of anxiety from the parents. What do you say? You can provide DDH resources and reassure the parents that you're referring the child to our specialist service for management, and whether that ends up being bracing or whether that means just monitoring, just providing that reassurance to the parents because they're highly anxious. This is their newborn baby or their first child. It's very stressful point for them. So when bracing doesn't work, so sometimes the bracing doesn't work because the hip remains dislocated. We attempt bracing, but we're not at that 1 or 2 week review. We're not successful in getting that femoral head back in the joint, at which case we would cease bracing and refer on to orthopedics. Or if the child is unable to tolerate bracing, they may have neurological condition or increased muscle tone. We're not able to brace the child. We would try various strategies, different braces, or refer to orthopedics. Or if the DDH persists despite a long period of bracing, in which case we would refer to orthopedics.
Now we put tolerate, unable to tolerate in inverted commas, because tolerate, the child doesn't say, hey mum, I don't want this brace, but they're sort of saying it, or the mum and dad are interpreting it, and tolerate is a very vague thing. So hence why we try all these different strategies to make it work.
Yes, compliance, I guess, being a component of that. So management of bracing. So we brace to try and obtain a normalized hip, and the success rate of bracing is 91 to 93%, and it's not statistically significantly different, the effectiveness of a soft dynamic brace such as a Pavlik harness versus a more rigid brace. And for those that we successfully brace, we would cease bracing, and then we would monitor during childhood to check that their hip continues to develop normally. And those that that are unsuccessful with bracing, this failure rate is around 7 to 9%, and they may go on to require surgical intervention and any complications possibly that may be also unsuccessful, such as AV and avascular necrosis.
Yeah, I tell when I'm teaching this stuff, I say, imagine you went to your GP to be treated for high blood pressure. Why would the GP want to see you again after they started medication? And I think there's 2 reasons. One, is the medication effective? And number 2, have you had any complications from the medication? So it's the same with hip dysplasia. If we brace a kid, we want to know, has the bracing been effective? And we want to follow them up through childhood to see if the dysplasia has recurred, which usually it doesn't, but it can. And secondly, have there been any complications? And the complication might be that we damage the blood flow to the femoral head, we get avascular necrosis, and that manifests as abnormal growth of normally the proximal femur. So even if our bracing is successful, we're still going to follow the kid up through childhood. And again, this is an area for research for us to know when and for how long. And we don't know at the moment. We typically follow them up till they're about 8 to 10, 12, when they've roughly finished growing. And we're not seeing them very often by that stage. So if it's unsuccessful, we then do surgical intervention, although it should probably be better phrased intervention by the surgeon, because it may not be surgical. And so we're going to finish off roughly now with what's the orthopedic management. And again, I love principles. So the principle is put the position, put the hip back where it belongs. So it's this relationship. If it's out of position, put it back where it belongs, so reduce it. And then after you've reduced it, keep it reduced. Like if it was only that easy, but the principles are easy. And for both of those things, we can reduce the hip either by an external process, which we might call closed reduction, or by an internal means, an open reduction. And then when we've done it, we can keep it reduced by an external means or an internal means. And I'll just go through these. I just had an ultrasound scan that shows a dislocated right hip. And instead of starting bracing at 8 months, because they're quite old and we're worried we might be trying to force the hip into somewhere it's not going to go, we don't know for sure, we're going to do an examination under anesthesia and an arthrogram and see if it's reducible. So here's their x-ray that we do just to check we're not missing anything else as a diagnosis. And you can see on the right, the ossification center has not appeared yet, and the hip is out of joint and the acetabulum is shallow. That angle is steep on the right. So we go to theatre and we do an arthrogram. And what the arthrogram allows us to do is to contrast between the cartilaginous acetabulum and the femoral head. And then we see, is it reduced? Now, in this case, the labrum doesn't look all that fancy, but they're 8 months old and it looks reduced. So we decide to go with a closed reduction. And then we keep it in place with a spiker. And it's called a spiker because when you put the plaster on in the old days, you used to weave it backwards and forwards in a crisscross manner that was meant to resemble the sheath of a wheat of corn, which is spiker, I think in Greek or something like that. So that's where the word spiker comes from. It's a spiker cast. And that's really just the same as Millie's brace was doing, except in this case, no one can take it off. Well, hopefully they can't take it off. So that's a closed reduction. And if we look at her x-ray 6 months later, the hip is in joint and it's starting to catch up and improve. Now, this is a 6-month-old female with a dislocated left hip. And for whatever reason, this is a case of my colleague Ben Johnson's. Again, we're not going to try bracing. We might have tried bracing. Some of these you can try bracing. He's got this kid here in a brace, but in the brace, the hip's not reduced. And we mustn't brace for long. You know, we can do a few weeks of seeing if it reduces, but we're not really, because if you brace it dislocated for months on end, you'll stretch all the tissues and have the femur and the hip joint the wrong shape because you braced it out of joint. So we might try bracing. If it doesn't work, then we're off to theatre. This is the EUA arthrogram. That's the dislocated hip. And then Ben's done some abduction to see if it goes back in. That's a dislocated hip popping back in, but it's not really sitting down properly and the labrum's not covering it. So Ben decided to do an open reduction, and then we hold it in place with a spiker and we do an MRI in the spiker cast to check it's in joint. And then lastly, this concept of holding it in place. So we might feel that the hip is subluxed or not quite right, and we're going to do our reduction by changing the shape of the bone, and changing the shape of the bone is also going to keep it better in joint. And osteotomy in Greek, osteo means bone and tomy means to cut, so osteotomy sounds really fancy. It just means cutting the bone. And believe it or not, I mentioned you've got the pelvis and the femur in relationship. So if you're going to cut a bone, well, you've only got two to choose from, the pelvis or the femur, and you can do one or the other or both. And I'm not going to go into the ins and outs of which one we choose here, but if you cut the pelvis or the acetabulum, you can get more coverage. You can cause the bone to come more over the femoral head. And if you cut the femur, you can get the femur more directed into the acetabulum. And basically, it's all about restoring this relationship.
And going from orthopedic discussions, GP resources. So Karen's going to speak a bit more about health pathways in a moment, but this is just one link to one screenshot from health pathways. Some other useful links, we've got the Victorian Paediatric Orthopedic Network. So this first website, this first link has a lot of different resources for a range of other common orthopedic conditions such as positional talipes, clubfoot, developmental hip dysplasia. The second handout is the DDH handout I showed earlier. And there is also a pediatric orthopedic referral guideline, this last link, which goes into a lot of other common referrals, such as in-toeing, out-toeing, toe walking, all of those things. It's a guideline that's quite useful. So I guess our takeaway messages. So all infants require hip screening at multiple time points that we went through. In addition to manual testing, babies with risk factors require ultrasound. And X-ray replaces ultrasound after around 8 months of age. that may vary depending on the size of their ossification centres, and ensuring timely referral to an appropriate DDH clinic, and including the relevant information with your referral will ensure timely orthopaedic assessment and management. So if there is some information not included in the referral, it may just delay when the patient is able to be seen. Thanks very much. Now we're down for some questions, and Karen was just going to go through quickly the other health pathways slides. Yes.
All righty. Thank you so much, guys. That was amazing. We always know it's a great presentation when you watch the questions coming in thick and fast with such interest. I'll quickly go from current slide. Here we go, look over. So most of you will be aware of health pathways, and if not, this is health pathways. It's hosted by the PHNs across Victoria. Obviously, this one is Melbourne Pathways, which is Northwest. Oops, sorry, I went one too far. If you don't already know, so it's written by GP, clinical editors, and using subject matter experts from various health services to work that, and they're great. Hopefully you're already all familiar with them, but if not, it's easy enough to register just by going to the PHN and clicking on health pathways, and it's free. So these are the relevant pathways for today's presentation. And oops, I'm sorry, I've clicked on the actual link. We don't need that. There we go. So you can see there's actually a section here on DDH and some advice about assessment and when to refer, etc. I'm not going to go into these guys. You guys did such a comprehensive job. You don't need me to be doing this in detail, but just to give you a bit of an idea of what's there. And you can see this is the bit of relevance, which is the referral. Now, there was one question, there's lots of questions, but one of them was just with regards to North area referral options. So this is the Western one, obviously, because that's us. There's also rural Melbourne, and you can't see here, but on the actual health pathways, that one there that's not on this slide says Northern Health as well. So they're the areas that cover the Northern region in answer to that particular question. I think that one has snuck in. Oh no. Not sure why it has general wound care at the top, but anyway, there you go. And so that's how you would register. So I'm going to stop sharing now and hand over. Now, we have had a great session, but we've got 9 minutes left, and there are 20 questions. So there's absolutely no way we're going to get through all of those. So what I propose is I'll pick and choose the ones that seem a bit thematic, and the rest, if you guys are happy to address those offline, maybe if we can keep those, if you've got the energy and zeal to address those offline, we'd love that, and we can circulate. Thank you, Chris. Circulate those to the people who attended tonight. So I'll just jump in and go. So there was a question about identifying bilateral DDH, because you mentioned that that's actually quite hard and not to assume just based on symmetry. Do you have any tips for that?
I think the key is that Millie suggested the abduction range should be like 70, 90. Kids are stretchy, so they should go a long way. And if they're not going a long way, you should be asking why not. And again, it's all about a hint that there might be hip dysplasia. And if it doesn't quite add up, or it's not quite, doesn't fit with normal, do your imaging. We had a kid once with bilateral hip dysplasia. Both hips were dislocated. They came a bit late, about a year old. And when we met the dad said, "Oh, I always wondered why she was harder to change the nappy than her older sibling," you know? And that's the challenge with symmetry. Asymmetry only works if it's affecting one side.
No worries. Thank you for that. There were a few questions about risk factors, so I might clump them together. So one was just checking in, and I think you probably covered this, but just to reiterate on the risk factors, if there are risk factors, are you ultrasounding at birth and at 6 months? I think they're asking about the guidelines for when to ultrasound based on risk factors. And then leading on from that was also about uncertain risk factors. So if it's a donor egg and sperm, so you don't have any past history, or there's uncertainty about the family history of previous DDH, etc., what do you do?
So in regards to the first part of that question about whether you do an ultrasound at birth, so we wouldn't typically do an ultrasound at birth. if you're doing the screening, we would normally then get you to do the clinical manual assessment. But if they come to our clinic, we might do an ultrasound, but not typically. The usual age that you would start doing ultrasound would be 6 to 8 weeks. That's usually corrected age. So one thing to highlight there, if you've got a premature baby that's 35 weeks, you should be doing it at that 6 to 8 weeks corrected.
Beautiful. And as you mentioned, Amelia, GPs often won't be the ones doing the manual assessment at that time of birth anyway. So, yeah.
And some of this is a throwback to the past. When I was a medical student, there was this double nappies or whatever era, not even the disposable nappies, the old-fashioned nappies, where if you had the clicky hips at birth, they would do double nappies for 6 weeks and reassess them, because that physiological immaturity and laxity is key in the first 6 weeks. So you don't actually get a lot of information. You see too many normal hips in the first 6 weeks to ultrasound them. So we really don't want to ultrasound too early. But when the birth unit says this hip is grossly unstable, the chances are it's going to stay unstable. So we would rather do that journey, hence why we want them referring to us. But the ultrasound really is more after you've overcome that initial immaturity.
No worries. I'm going to jump to another question, but just before I do, I was supposed to say, just as people are starting to leave early, if you've got a single name in your Zoom and you haven't communicated with Yvonne through the chat function, and she may not know both of your names in order to get your CPD, please don't forget to either change your name on the Zoom to both your first and surname, or let Yvonne know in the chat. Okay, back to questions. What is felt to be the rationale around the higher incidence in females? I don't know that we covered that.
Oh, we probably didn't talk about that. Usually the rationale is that the female babies tend to uptake a lot more of the maternal hormones during pregnancy, which can just stretch and make their joints more lax. So normally during pregnancy, of females, the extra hormones will allow all of the joints to be more lax to allow birth through the birth canal. And often female babies will uptake that and have more joint laxity.
Love it. I love it when an answer makes perfect sense, and we'll remember that one. There was a question here about swaddling, which I know you did talk about the problem with adduction, but is that then a don't swaddle, or is that a swaddle with care or something else?
So there actually are some swaddling resources on that last link that I said, the resources. Swaddling for hip dysplasia. So we usually prefer, you can swaddle, so it's good to swaddle the shoulders and the arms, but loosely around the lower limbs, so that the hips are able to go into that natural frog leg position. And there are a lot of like baby sleeping bags, those Love to Dream sleeping bags that are DDH approved, that have a lot of room around them for sleeping in.
Beautiful, thank you. There are a couple of questions about the challenges of some of the guidelines that were in here compared to what happens out in the real world. And there were two of them in particular. One was about radiologists wanting to X-ray after 6 months rather than after 8 months. Did you have...
with the kids at the moment, we've basically got a hip registry, and we're also got a big grant to do more work. And we want to... basically try and look at all of these things and rationalize it. There's a lot of different information coming in from all different places to radiologists. But we would argue, well, what we do, what we can only really recommend in some ways what we do, which is that we try and string out the ultrasound for longer. We try and string it out until literally someone says, oh, the ultrasound's no good, which roughly is going to be about 8 months, maybe 9. We try and string it out, because sometimes you can save a baby 1 X-ray, and it might not seem like a big deal, but you can save them 1 X-ray.
Okay, so it's probably reasonable if being sort of pressured by paediatric radiologists to X-ray at 6 months to sort of gently say, look, there's probably scope to do another ultrasound.
Yeah, could you try the ultrasound first? They've got not a lot to lose by trying it. But that's where it almost comes in. Should we be nominating certain centres? We're not there yet, but should we be having a recommended list of imaging places for some of these things? That's a hard one.
And given that the GPs are the ones referring the patients for these images, and often they're private fee paying, I guess something to consider would be to tell the parents at those borderline age brackets that these are the pros, that, the informed consent, that there is the no radiation for the ultrasound, but you may still have the cost, and may still have a cost involved to have an X-ray as well if that's required. So I guess if you can communicate that with the family.
Yeah, and they're expecting it at least. The other guideline that was that seemed a bit so was the comment about 3 months maternal child health visit assessment. Someone's pointed out that in the Victorian guidelines, the maternal child health visit is actually at 4 months, not at 3 months. And I don't know where that fits into your assessment.
No, what it is, Karen, orthopedics think in 6-week units of time. So when we put a forearm fracture in a cast, it's 6 weeks in a cast and 3 months of whatever after an operation. So we always think 6 weeks, another 6 weeks, which makes 3 months. So for us, 4 months is a really alien concept in orthopedics. It's not really that the guideline's wrong. It's just that it represents probably more the way we think.
But you can cope with it being 4 months rather than 3 months, rather than no increased risk. Yeah, that's fine.
When we put this talk together, if we'd have had more time, we could have tried to link in more with what those other guidelines say. We were really more going off what we've historically taught, but I definitely wouldn't say it has to be 3 months, 4 months. They're not big issues. Yeah.
No worries. Now, there were a couple of questions. I'll blend them, I think, but I think the guts of them was along developmental issues as far as babies come out, may or may not have risk factors, seems to be okay with the manual test, but down the track, there's noted some either creases or perhaps the manual testing issues, etc.
Yes.
Is that a thing?
Is that if they've been braced and finished bracing?
No, this is a non-DDH.
It's like, that's why we want to stress this, don't call it congenital dislocation of the hip, because A, it might not be dislocated, and B, it might not be congenital. So developmental dysplasia is the term, and that has this word developmental in it, and it has it deliberately there because some kids may appear to develop the dysplasia at an older age. And it begs the question, were they just not tested by someone who did it well? Obviously, manual testing itself has a failure rate because we see kids come with late dislocations and stuff like that no one picked up. So it's really hard to know, did those kids have a dysplasia that was always there and not picked up, or did they have an element that got worse? It is possible that some had an element that got worse.
Yeah. Okay. So this was about, they've been cleared at 6 weeks, they've been cleared at 3 months, just the routine clearing. And then at 6 months, can they develop it? So it sounds like, yes, that's possible, but were they missed or was it developed later?
Yeah, very hard to know.
Just for the benefit of our 101 attendees, are you guys happy to continue for another 5 minutes?
Yeah, easy.
5 minutes over, is that all right? And then anything left from then on, we'll take offline. So there was a question. Clearly, I must have been answering some questions because I know you talked about this, but in the third trimester with breach, the question's to do with is it an increased risk at any time, breach any time through the third trimester, or is it only risk if it's sort of in the later stages of that third trimester?
Anytime, from 32 weeks on that.
Right.
So even if a baby's been in breach and they've had a scan and been noted to be breech, but then they've turned and then still been born vertex delivery, they're still breech. They have a breech risk factor.
Have a think about yourself. I can't put my leg behind my head. Some people can. And it's related to my hamstring's length. And my hamstrings cross two joints, the hip and the knee. And I can, if I dislocated my hip, I could put my head behind because my hamstrings have suddenly become detensioned by having the hip pop out. So you've got this whole concept of the breech position is really, it's not just hamstrings, but it's this tightness and the position that has the hip coming out.
Thanks for the visual, Chris. That's fantastic. There was a question, and again, I didn't hear, did you guys talk about acetabular index as well as the angle?
I did on the X-ray. It's that angle between the Hilgenreiner's line and the acetabular roof. And I think we have to do some education work with the radiologists about what are acceptable parameters.
This question's about normal parameters at different ages, so 6, 12, 18, 2 years, and whether that changes over time.
Yeah, normally by the age of 1, we would like it under 30, probably ideally under 28. And by the age of 2, we'd probably want it under 26 degrees.
Yeah, okay.
But
sorry, keep going.
But there's an element of other aspects of dysplasia. So is Shenton's line broken? And this is where it's really handy if we can log on and look at the image, because we might log on and look at the image and just say to the GP, hey, we would like you just to repeat this X-ray in 1 year's time. That'll save the patient a visit to us. You can carry on manage them because we're not convinced it's dysplastic. And when you get into those older age groups, you're not going to go for bracing. You're not going to brace a 2-year-old. So if we saw an X-ray in a 2-year-old with query, is it or isn't it, we might actually advocate, let's just repeat the X-ray in a year. So
Great. So that actually addresses a couple of questions for the later age. So one was, what X-ray views are needed to diagnose dysplasia in the older groups? Would mild dysplasia still need a referral or just be managed with strengthening? So that's...
Yeah, we would be asking this question about when we say mild dysplasia, which direction's it heading? Is it going better or worse? And the older the child, that cartilage is no longer molding and shaping. So you get your best bang for buck bracing a little young baby, the first months of life. When you're getting to a year or more, your bracing is really tailing off on its effectiveness. By a couple of years, your shape has already formed a lot in bone. And so we would not suggest any GP hanging on to those patients without some input from us. We would say, don't say, oh, it might be mild, it might not. Get an opinion from us, because then it becomes something that for us, it's like quite specialist in the first place. So we would like to see that.
Yeah, and that leads nicely to this one, which is about evidence-based management options for those older children, because they're not going to be braced, one would assume, and they don't need, well, in this question, they don't need surgery. What are some of the management options?
Well, that's a real challenge, because I don't think there's a lot of evidence for anything really making your hip better. There's an age group where you're almost going to wait and watch. You're not going to operate maybe on the 2-year-old for mild dysplasia. 2-year-old comes with a dislocated hip, you're definitely going to put that back in. So if I saw a 2 or a 3 or 4 or 5-year-old, maybe, and even older with a dislocated hip, unknown until it was found out, we're going to do an operation to put that dislocated hip back in. Without an operation, it's never going to crawl back in the socket. But what you do with the 3-year-old who's got, the acetabular index is a little bit higher, because then you're faced with, do you commit to a pelvic osteotomy or a femoral osteotomy? And some of those, we might give it the benefit of the doubt and wait. We're not going to wait until they're 10, but we may well wait a year. But we would like that waiting to be on our radar. But I don't think other treatments, like we wouldn't send them for physio, we wouldn't see them as having an adjustment or someone's going to put something back in. We don't view that is the way it structurally works. What we consider is that we're probably too late for bracing, but before we commit to an operation, we want to know, is this a bad hip getting worse, or is this a bad hip that might actually be getting better?
Yeah, beautiful.
And hence why we want to do the journey with the patient.
Thanks. This one's a quick one, I think. It'll probably be yes, no, hopefully. Is hemiplegic cerebral palsy a DDH risk factor, and should this be screened?
Yes.
But that's usually via the...
I think any neuromuscular, we haven't talked about neuromuscular, that's a whole other thing than neuromuscular hip, but any neuromuscular imbalance, the hips are at risk. Now, hemiplegic CP is low risk. Diplegic, and we can't go into it here really, but my colleague Kerr Graham at the Children's has done a great research paper looking at the hips according to something called the GMFCS, the Gross Motor Function Score. And you discover the more disabled the child, in other words, the more likely they are to be in a wheelchair and highly disabled, the much more likely their hips are going to dislocate. Whereas the hemiplegic, not really. But we do sometimes see hemiplegics with hip problems, but it's more, the more disabled, the more of a non-walker you are, the more you've got to keep a close eye on the hips.
Those sorts of patients should usually be referred to the Royal Children's for hip surveillance. They wouldn't come under our DDH clinic.
Perfect. Thanks, Amelia. So these 3 are about braces. One is, what's the clinical reasoning behind fitting the DB over the Pavlik harness and find better results using a DB brace? Was that the whole question?
One answer I give to that is that I've got a Mac and you might have a PC. Which is better?
The Mac, clearly.
Yeah, I agree the Mac's better. And Dr. Pavlik felt his harness was better. But anyway, carry on, Millie.
I think, well, previously we used Pavlik harnesses a little bit more for the unstable hips. And then just from the training that I've done at the Children's Hospital, we tend to use a bit more of the Dennis Brown brace. The Pavlik harness does need a lot of frequent reviews due to risk of skin issues, because it covers the whole body, risk of femoral nerve palsy, risk of avascular necrosis. So a lot is sort of preference, surgeon preference.
We're hoping that our work at the Children's, our registry, because Monash has got a different practice than here, than
Yep.
the children's, all of us. So we're hoping that our registry might help tell us, a bit like hip replacements, what's the best hip replacement, you know,
Yep.
anterior approach, posterior, you know, plastic, ceramic. We're hoping that our registry will help answer those questions for us.
No worries. We're nearly there. There's 4 more questions. I'm just going to finish them off.
Oh,
So two of them are bracing ones still. One was to do with weaning from braces. With regards to the case study, does the weaning process typically go down from 24 hours to 23 to 22 in the DB to cessation?
Usually we go like from full time to 23 hours, and then it varies. So it's sort of, it may go, we may just give a little bit extra time, or we may go down to nights and naps, or may just finish straight away. So it's not always the same. It's patient dependent.
Nights and naps is a common thing. We go to just whenever they're having a sleep, they wear the brace. That's often our step down.
Perfect. Okay. And then the last bracing question was about follow up. How often do kids that have been braced get followed up, etc.?
So if they're a stable hip, then we would scan them every 6 weeks. If they're an unstable hips, it might be, oh, that just stopped screening. It might be every 1 to 2 weeks initially.
Yep. Yeah. Thank you.
And then later on, when we're doing when we might do our X-ray at age 1 year, and then if everything's looking good, the big challenge then is, when do we do it again? Some people might not do it until they're 4 years of age. If it was one of these where we picked it up really early, we braced them, the serial ultrasound showed it responded straight away, and we got a good hip within 6 weeks, then the big question is, when you get to a year with a normal X-ray, do you even need to see them? We don't even know that question, but we tend at the moment to probably see them maybe at 4 and 8 or something like that. But it's all a bit variable.
No worries. 2 questions to go, but those who are still here, if you're happy to screen that QR that's on just for feedback, because we do listen and look and make changes from that. This one is, do we continue to do interval imaging if the imaging shows grade 3? I might have answered that actually already, I think.
Yeah, so they're completely dislocated, terrible here.
No, refer straight away.
What we're going to do with those is we're going to
answer that one.
Yeah, we're going to sort of see it in light of, are they better to have an EUA arthrogram? We're worried some of these hips to force them into places. So it depends partly on the age, but we want to get a feel for how easy is it to reduce this hip, and sometimes you can get a better assessment of that under anaesthetic.
Yep, great.
We might just do the EUA arthrogram and put them in a brace, you see, or we might use a spiker just for 6 weeks and then do bracing.
Okey-dokey. I haven't read this one yet. So what do you recommend requesting when asking for a hip X-ray for suspicion of DDH? I think that's just to do with the wording to put into
it's a great question. I think if the child is older and they're weight bearing and not in the terrible 2. So if you think you've got a child that's likely to comply with an X-ray and stand, so like 3-year-old upwards, get a standing AP pelvis. If they're not of standing age, not of complying age, get a supine pelvis. But again, one thing we've had to do is a lot of education for radiologists. So the people who take the picture, they're often they're taking an image and the child's crying and struggling and someone's holding the leg. And if they hold them wrong, that relationship between the femur and the acetabulum, because the child is lax, if they're struggling and pushing, you'll end up with a hip looking subluxed when it's misleading. So a whole other area for us to do work on is how you position the child for an X-ray. And that's where maybe, again, to choose some of these super centers that might be better, or at least we're trying to get some education out there for that. But supine generally, if they're not weight bearing age or not compliant, standing if they're of an older age.
I think you guys are superstars, because we've only gone 12 minutes over and there was 20 questions in 10 minutes or so. So you've done very well. Thank you all those people who've stayed on. There's lots of you I can see. I hope that was incredibly useful. I know I learned heaps. So thank you, Chris and Amelia. If you guys want to just hang on for a moment.
Yeah, no worries.
Great. And we'll bid everybody else good night. Thank you. I hope you found that really useful.
Thanks very much, everyone, for attending.